This podcast is brought to you by the School of Advanced Study, University of London.
Well, thank you for your patience. I'm sure, like many of us, you struggled with what seems to be going on in the traffic world around here. It is a great pleasure, as chairman of the Link Foundation, to welcome you to Senate House. When we set up visiting professorship arrangements 4 years ago, our plan was to try to bring over people of distinction who could really handle the exchanges in areas of common interest between New Zealand and the UK, but very much with the thought in mind that one of the outcomes would be there would be a genuine legacy, that connections would be reinforced, existing connections, new connections established, so that after our distinguished visitors returned to New Zealand, that there would still be a flow of information and connection and research and communication. Much of it depends, of course, if not all of it, depends upon the effectiveness and the commitment and the area in which our visiting professor is active. To date, all of the previous visiting professors have built legacy, and it's so clear to me that Robin Gauld, who has done so much on this journey, he's packed in visits and seminars and talks and closed discussions, and has been immensely busy, that he will leave very much behind him the foundations of legacy and the way that we have always aspired. What is going on in the health systems in both countries is showing, from the lecture I've heard already from him, immensely important parallels. And so tonight, to have this lecture on clinical governance leadership is a very fitting way of bringing more or less to a conclusion. The way in which he works and the number of people who want to talk to him, I suspect is not the conclusion. But it is a very appropriate way for us to finish the formal lecture series. So I'd like to take this opportunity publicly to thank you so much for all you have contributed and for all the effort and interaction that you put in. It's very, very much admired. The only bit of two bits of housekeeping I have to tell you about. One of them is not to forget to kill the monster. Please turn off your little laugh machines. And secondly, in the unlikely event that there is a fire alarm, you are required to assemble in front of the building on Mallet Street, which is all you need to know. It is my real pleasure now to hand over proceedings to Sir Malcolm Grant, another New Zealander. We worked together quite closely during the time both of us. I was looking after the central bits of the University of London, and Malcolm was very effectively leading University College. And so it's nice to have you here back on our territory, Malcolm. And it is my pleasure to hand over the proceedings to you.
Well, thank you very much, Graeme, and welcome everybody. Our thanks go to Graeme and to the New Zealand UK Link Foundation for not only hosting the event this evening, but also for making it possible for Robin to come over from New Zealand and to participate in a wide array of events over recent weeks. I have a few more words to say about Robin in a moment, but just to, if I may, set some of the context for the lecture tonight, which is on these joint themes of clinical governance and clinical leadership. I would suggest they're different. Clinical governance is to do with how we ensure continual improvement in the quality and safety of care that we provide for patients. It's a critical aspect of any nation as it provides a healthcare system, and particularly emphasis in the 21st century when our capacity to deliver safe and effective healthcare is better developed than at any time in history, and our capacity to cause serious damage is better developed than in any time in history. Modern medicine is both outstandingly successful and outstandingly dangerous. And so to have proper clinical governance to drive up quality and to achieve safety, to overcome that extraordinary dichotomy of language that we use in this country of so-called never events, events that should never occur, but actually still do. And these are themes that I hope that Robin will be addressing tonight. And clinical leadership is, I think, a parallel but concurrent theme of trying to ensure, certainly as far as we're concerned within NHS England, that we align the resources with clinical judgment, as opposed to aligning resources with some sort of top-down idea of what targets there are that need to be achieved, and in a uniform basis across the country. Unless you align the resources with clinical leadership and with clinical judgment, you're bound to have a mismatch. And every health system in the world, I think, has two problems. One is it doesn't apply its resources effectively to promote the most high-quality clinical care uniformly to all citizens. And the other one is that there isn't a healthcare system in the world, in the development world at the moment, that is financially sustainable into the medium term. The pressure on healthcare systems is rising with aging population, with longevity, which is to be celebrated. Graeme and I both jointly celebrate the phenomenon of longevity, and I see looking around the room we're not alone. But it comes with huge cost for healthcare systems. As we try not just to prolong life, but to prolong the quality of life. That requires a much more joined-up approach to health and to prevention of ill health than we've been able to achieve. So these two themes of clinical governance and clinical leadership are absolutely essential to understanding how we improve what we do in our healthcare systems. So to have the privilege tonight to introduce Robin is of enormous honour to me, to be able to identify a Kiwi who has taken a professional interest in both of these themes, and to understand them not only from the perspective of his own country, from New Zealand, but also to be able to track the relationship between what New Zealand does and what this country does. Because actually there's a long pattern of learning between the two. Frequently we have learned the mistakes of what we've done just before New Zealand's picked it up and replicated it there, and likewise backwards into this country. Robin holds a chair in the greatest university in New Zealand. Well, it is, seriously, I mean, I could not brook any disagreement about the University of Otago, as many of my colleagues insist on calling it Otago, but it is actually Otago, which had the first medical school, and I think for almost a century held on to that distinction until Auckland founded a medical school subsequently. But Robin has the position of Professor of Health Policy in the Centre for Health Systems in the Department of Preventive and Social Medicine, which has also historically been a very strong department at Otago. So without further ado, it gives me enormous pleasure to introduce our guest speaker this evening, Professor Robin Gauld. And when Robin has spoken, I'll introduce Dr. Anna Dixon, who will give a response. But let's first of all please welcome Robin Gauld. Robin.
Well, kia ora koutou, and good evening. It's a really special time tonight being here at Senate House, because this is the fourth and final lecture in my formal series of lectures here as the NZ UK Link Foundation Visiting Professor. So this is a completely appropriate place to be at what has been my home base, the School of Advanced Study. And I'm enormously thankful to SAS for having hosted me academically. I want to say thanks also, especially to the Foundation. What a wonderful, wonderful organisation, and to have been the recipient of the visiting professorship is something that it's very, very difficult to put into words. So I want to say thank you especially to Sir Graeme and to all of the trustees of the Foundation for having backed and supported me, to Lisa Fletcher especially, who's the chief organiser with the Foundation, and I've said that I think I've said this 3 times already at lectures. If you want anything done, Lisa is the person to go to. She's the most fantastic organiser that I've met. So Lisa, thank you very much. And I want to say a very, very special thanks to my family who just 48 hours ago set foot in England. We've been apart for 8 weeks, which has been quite a testing time, I think, in some ways, as it is when a family is apart for a while. But they've made it, and if you see them breaking out the porridge bowls, it's because it's breakfast time in New Zealand right now. So Ina and Edward and Anna, it's great to see you, and thanks for coming along tonight. Now, before I move on, this topic of clinical governance and leadership is a topic which to me is one of the most fundamental to healthcare systems today. And that is because clinicians are in a particular position in terms of their capacity to both lead and to build better healthcare systems. And so to me this is, as I say, one of the most founding principles for a healthcare system today. It's this idea of clinical governance and leadership. So what I'm going to do is explain a little bit about the idea and then move on and talk about some of the research that I've undertaken in recent years on the topic. But before I do so, if I can get the computer to behave and find the slides. Here we go. Let me just remind you how far away it is that Sir Malcolm and my family especially have come from. Dunedin is the furthest city in the world from London at 18,982 kilometres. It sits at the same latitude as the south of France. It would be very easy, especially for one of those 500 doctors a year from the NHS who go to New Zealand to practice, to think that it's a life in the sun. It's not quite. It's a gorgeous, gorgeous part of the world, but it's certainly not quite a life in the sun. So just in terms of what we're going to talk about, I'll briefly touch upon New Zealand's healthcare system, then look a little bit more at this concept of clinical governance, what's it all about, how might we define it, and then talk about the policy in New Zealand around clinical governance and clinical leadership, and then talk a little bit about the work that I've been involved in evaluating this policy, and then draw some brief conclusions. So in terms of New Zealand, this is just to remind you again of what New Zealand looks like. It really is mountains, lakes and sheep and the occasional person. We are a mid-range economy. We sit below the UK when it comes to GDP per capita. Our population is small. It's less than half of the population of metropolitan London, and it's widely dispersed across the 3 islands of New Zealand. 1/3 of the population live in Auckland, 1/4 live in the entire island of the South Island, and 1/3 of the South Islanders live in the city of Christchurch. It's a very dispersed population. We are increasingly internationalised, and last year's census revealed that 1 in 4 New Zealanders were born outside of the country. So we are very much, and always have been, a migrant population. The number one source of migrants continues to be the UK. We have, of course, various inequalities in life expectancy and disease morbidity. These fall disproportionately on Indigenous Māori people and Pacific Island people in New Zealand. Our healthcare expenditure continues to be above the OECD average, as it has been now for about 7 or 8 years, and so it sits above that of the UK as well, which sits on the OECD average. Our government spends exactly the same proportion of total health expenditure as does the government of the UK at 83%. And we are a big employer in terms of, well, healthcare is a large source of employment for New Zealanders at currently 4.75%. So when it comes to the healthcare system, this was founded in the Social Security Act of 1938. Now this was the world's first attempt to create a national health service, some 10 years before the NHS here in the UK. Now because of the resistance of the all-powerful medical profession at the time, we never quite got there. What we did get was free public hospitals at point of service, and these hospitals salary all of their staff, including medical specialists. And then we have private GPs, as you have here in the NHS, but our GPs only receive about half their income from government sources, and the rest comes from co-payments. And so you will always pay to see a GP in New Zealand. Currently, for me, it's about £20. For my children, I think they would be paying more like about £12.50. There is always a co-payment, and this is a barrier for about 20% of the population. Data routinely show will avoid seeking medical care because of cost to see a GP or to fill a prescription. We are the only country in the world that has a democratic governance in its healthcare system, and this is expressed through 20 district health boards. Now these are a bit like, you might say, local commissioning organisations. Some would say there are far too many of them in such a small country. Each has a chief executive and runs public hospitals and is responsible for essentially planning and funding services for a geographically based population. And these boards are predominantly elected, and then also a small proportion of the board members are appointed. The boards in turn fund 30 primary health organisations. Now these are responsible for coordinating primary care essentially. We've had, compared to the UK you might say, comparative stability. These basic structures have been in place since about the year 2000, but if you look more deeply at New Zealand, we've actually had a considerable amount of reform going on within the healthcare system as well in recent years. But that would be an entire course to delve into those details. So on to clinical governance. What's this all about? Well, the origins are here in the UK in contemporary terms, because some would say that clinical governance is actually a revisioning of a much older idea when it comes to healthcare organisation, and that was that doctors and nurses and administrator would work together as a team to run a public hospital. They would call it the triumvirate structure in the old days. Now, clinical governance in contemporary terms emerged here in the late 1990s and was expressed in this now classic paper by Skelly and Donaldson, who delved more deeply into what is this all about, where has it emerged from, and why is it important. And their argument, essentially recapping what had become government policy at the time, was that clinical governance was really about building a system through which health organisations are accountable for continuously improving the quality of services and safeguarding high standards of care by creating an environment in which excellence in clinical care will flourish. Now when you read this, you can say to yourself, well, that's all very well, what does it actually mean in practice? And if you delve more deeply into some of the ideas in here, it actually is a fundamentally important set of concepts that sit within here. So as Sir Malcolm said at the outset, this is about focusing on continually improving the system that you and I as patients are potentially going to be either victims of or the grateful receivers of really good quality care, no matter who you see or where you are seen. And so it's about clinicians getting involved in safeguarding standards and peer review, because at the time when this paper came out, and then there was a lot of noise about this in the UK, there had been some fairly nasty lapses in standards of care and some problems to do with the way in which healthcare professionals, doctors especially, were involved in oversight of one another's professional activities. And so these ideas also sit behind this when we talk here about creating an environment in which excellence in clinical care will flourish. Now, I quite like this particular idea, which the previous definition feeds into, and that is that everyone who works within that system of building excellence in clinical care has two jobs. So their first job is being a great healthcare professional, and that's what we expect of our healthcare professionals when they come out of medical school or nursing school or pharmacy, is that clinically they are excellent in terms of their capacity to treat patients. But they also have another job, and that is improving the system within which they work. And so clinical governance to me is about this two jobs concept. And it's quite a simple concept, and I think a very powerful one. Great healthcare professional, but also improving the system which those professionals work within. And so you could say it's a joint responsibility. Now when you have this two jobs concept functioning, this provides the organisational fuel for quality and safety improvement. And so we might expect to see, when a clinician says, well, what does clinical governance mean in practical terms? You might expect to see some of these things. And clinical governance is, to be fair, a rather woolly concept, and I think this is what often confuses especially healthcare professionals who are quite used to specific clinical knowledge which they can then put into clinical practice. And so they might expect to see some of these things. Health professionals leading improvement of the system, and so this is the clinical leadership idea coming into play, leading the organisation of care and the improvement of the delivery process. Being involved in stepping into leadership positions as well as leading by example and leading change. And then of course a workforce who are engaged, and this is a concept which we are seeing more and more in the NHS and in New Zealand as well. And engagement is all about being proud for the organisation that you work for, being committed to that organisation and working to improve that organisation. And so a workforce who are engaged and committed to service improvement and to better patient care, of course, and then very, very importantly, this idea of clinical oversight of the organisation. So in many ways, when you talk about clinical oversight, I like to think of clinical governance in terms of turning our healthcare organisations into what universities look like, at least the University of Otago where I work, and I believe many, many other universities are governed in the same way. And so that all of the key positions in the organisation are held by people who are professionally trained. So in a university you have everyone from the Vice-Chancellor through Deputy Vice-Chancellors, Pro-Vice-Chancellors, Deans, heads of departments, are all professionally trained. They are all academics who have done a PhD degree, forged a career in research, and moved up into administration and leadership. And so, in many ways, clinical governance is about turning healthcare organisations into units, organisations, systems that are led by healthcare professionals who work arm in arm in a partnership with administrators, which is how universities work. So Chief of Finance, of Human Resources, Planning, and so on and so forth, information technology. Now, most of our healthcare organisations don't, certainly in New Zealand, currently look like that. And so clinical governance is about changing the system to look more like a university-type system. There is of course, an evidence base emerging that provides strong wind into the sails of clinical governance and into clinical leadership. And so we had a very important report that came out in 2010, produced by the McKinsey consultancy in conjunction with a group from the London School of Economics. Now this was a study of about 600 hospitals across several countries, and what they found was that those hospitals that had clinical leadership in place were more likely to perform well on various financial and quality improvement indicators, as well as to have systems in place that could be followed by practitioners who work within that hospital. So we're talking about systems of clinical care that are agreed to by clinicians and various other systems in place. Now there was a 2011 study by Amanda Goodall, who lives here in London. She's at City University now, which provided further backup and support for the concept of clinical leadership. This was a study of 500 North American hospitals, and again she found that those that were led by a doctor had much better performance on the quality and the financial and other indicators that she looked at. We've had two quite important reports produced this year. The one on the left-hand side is a product of the American College of Physician Executives, and this is essentially a review of the evidence, largely in a North American context, for clinical governance and clinical leadership. And they illustrate in this report that of the top 20 North American hospitals, about 15 or more are clinically led. They're led by a doctor. Now the report on the right was produced just a few months ago by the King's Fund here in London, and this report looks more specifically at this idea of medical engagement. Now they argue that if you get the medics right, if you get their structure and their engagement with the organisation right, everything else should follow, because the doctors are so pivotal to a functional organisation. And so they discuss the importance here of leadership for medical engagement, so that you can ultimately get a system of clinical governance that includes various other health professionals, all focused on improving that system. Then we have organisations like the Geisinger Health System, which some of you may be familiar with. This is in rural Pennsylvania in North America, quite difficult part of the country. They face many problems to do with socioeconomic status and healthcare problems that are associated with that, and it's a very geographically dispersed population. Now Geisinger many, many years ago said, we're going to be the best at what we do, whatever we do in North America. And President Obama relatively recently has said that if we all had a Geisinger, we would have the best healthcare system in the world. Geisinger is a clinically led hospital system. They provide both an insurance program for those who want to enroll with them, as well as run a hospital system. And they have, as in this example, worked on various different components of care delivery and said, we're going to create a system that we've all agreed to and all adhere to. And so this example here is of coronary artery bypass graft surgery. And so what they did is they sat down the surgeons involved in CABG procedures, the technicians, the nurses, the laboratories, anyone else involved in that process. And they said, how's this going to work? And they drew upon the best available evidence from studies that had been produced into best practice, safest care with CABG procedures. And in the absence of evidence, they said, right, if we've got 6 different ways that we perform this procedure, which one is the one best way that we're going to follow? And they agreed to this and put in place 40 steps, which they now all follow. They, of course, in wonderfully North American style, called this proven care and trademarked it, meaning that if you have a problem with your procedure, they have a money-back guarantee. They will fix the problem and, I believe, return your money to you as well. Very importantly, though, in the context of tonight's discussion, they have shown that they've both reduced cost of this procedure because of reduced complications, improved efficiency, and reduced readmissions to hospital, while also improving the quality of care. So on to the New Zealand example of clinical governance and our assessment project, which I have led over the last few years. So we had in 2009 a relatively new government, and Health Minister and Tony Ryle here on the top left hand. This is the government that is still currently in place in New Zealand, just re-elected about 2.5 months ago. Now, Minister Ryle came into his position having spent a lot of time talking with healthcare professionals in opposition. And he came into power and said, you know, we're quite serious about making sure that we create opportunities for clinical governance, for creating a system, as well as clinical leadership within that system. So he set up a working party on clinical leadership, which produced a report in late 2009 called In Good Hands. This is a very short report. It's quite a good read. It's only about 8 pages, and it drew heavily on activities within the NHS, including the NHS leadership, I've just forgotten the name of it, the NHS Leadership Framework, I think it's called. And they produced several recommendations for New Zealand's 20 district health boards. They said that the DHBs should create strong clinical governance structures, if they didn't have such a structure in place already, ensuring that there was a partnership between both executive leaders as well as healthcare professionals, and that they had joint accountability for both financial performance as well as quality of care performance. That there needed to be support for strong clinical leadership and decision making throughout the district health board, so from the top levels right down to the front lines of care. And then that the district health boards, very importantly, should seek to identify and support clinical leaders. So the Minister straight away said that he endorsed this report in full and expected the DHBs to implement its core recommendations. He said it was not about an upheaval, it was about operating differently to develop and support strong clinical leadership and governance throughout the health system. So I thought, well, that's all very interesting, and as I said at the outset tonight, very, very important initiative in terms of public policy and healthcare policy. So about 12 or 13 months after his announcement, I went to the Association of Salaried Medical Specialists because it appeared that there was no evaluation of this policy rollout taking place. The Association of Salaried Medical Specialists is our public hospital doctors union. The consultant doctors belong to this union. There are 3,400 members. About 90% of public hospital doctors belong to the union. And I said to them, I'm quite interested in doing an evaluation of the clinical governance policy. Are you interested in partnering up on this? They came back after a little while and said, yes, we are. And so we then created a very, very short and simple survey which essentially sought to gauge the implementation of each of the core recommendations from the In Good Hands report. Basically, we were seeking to ask this question around the extent to which the district health boards were implementing the recommendations. Now, we, on the back of this work, based on the survey data that we received in from the specialists, created what we called the Clinical Governance Development Index. And this gave an average score across the DHBs of 46%. It was quite controversial, ranking and rating the districts in this way. There was quite a variation between the districts. The top performing district, however, only got just short of 60%, and some were much lower, of course, than the 46%. We were fortunate enough to have our study published in the BMJ Quality and Safety, which is arguably the top journal in the field, and it has since been replicated, at least on a pilot basis, in the Irish Health Service Executive across various hospitals in Ireland. So it had quite an impact. The Minister of Health was delighted by our work when he caught wind of it, and he then asked each of the chairs and chief executives of the district health boards what they were going to do about their score on this index. Some of them said, well, we'll be working hard to improve it. Others were quite irate, actually, and received some phone calls from irate chief executives saying, what on earth do you think you're doing? So I'm a researcher, and I've got a critic and conscience. It's very important to do this kind of work. And many people felt that our findings were really quite accurate. In the subsequent year, in 2011, I was approached by a mix of central government agencies to conduct a follow-up study, and that's what I'm going to talk about now for the next few minutes. This was a much larger study, and it ended up being a partnership with the 20 district health boards. We had a much broader scope for this study. The government was interested in including all healthcare professionals, not just senior doctors, in the follow-up study. And so we conducted the largest ever survey of registered healthcare professionals in New Zealand. A little over 41,000 were invited to participate in our survey study. And as I say, this was a partnership with 19 of the 20 district health boards because Canterbury District Health Board was still in the earthquake recovery process, in fact very much in the thick of it. So they did not participate. But essentially we partnered with the district health boards who undertook much of the sample generation and the mail out, and then we managed the data collection process and analysis process. We also conducted a series of case studies, so this was one of the most fascinating projects for me because it meant visiting all 19 district health boards in New Zealand. So it really was planes, trains and automobiles for about 3 months visiting these various districts. Each district health board conducted a brief self-review of what their activities were in order to promote and support clinical governance, building the system, as well as support leadership within the system. And I personally was involved in interviews with 165 interviews with 165 individuals, from chief executives through to hospital specialists, nurses and allied healthcare professionals across those case studies. We held a final meeting in Wellington at the end of 2012 where we produced 2 reports which are available to download off our website, and they provide considerably more detail than I'm going to discuss tonight. So on to some of the findings, and I'm just going to touch on some of the more important ones. These were our respondents. Now some would say, well, 25% is not a terribly good response rate, but we in fact got a 10,000 plus respondent group. And my colleague Simon Horsburgh, who's an epidemiologist and sometimes statistician, says this is actually a very solid database. We've looked very closely at the characteristics of respondents and non-respondents and found really not much difference between the two. So we're quite confident in the data that we have. So just looking at some of the questions that we asked. Now this is a statement that came directly from the In Good Hands report, that clinical governance and clinical leadership could be described as a new obligation to step up, work with other leaders, both clinical and managerial, and change the system where it would benefit patients. So we asked respondents, how familiar are you with this concept? 47% said that they were familiar or very familiar with this concept. And you can see some variation across the districts. The better districts at the top. And if you look closely at these slides as I go through, I'm not going to keep them up for very long at all, but there is a group that tend to be at the top and a group that tends to be at the bottom. We asked about the extent to which respondents had sought to take up opportunities to work with other staff, clinical and managerial, to change the system where it would benefit patients. Because clinical governance, clinical leadership, it's not just about creating opportunities, about saying we've got a system here. It's also about, as I said earlier, 2 jobs. Being a great clinician and also stepping up and getting involved in improving the system. So we asked a question along those lines. You can see here that 75% of respondents said that to some or great extent they'd sought to take up such opportunities, with a little bit of variation across the districts, but not a lot. So you could say this is quite a positive finding. We asked whether respondents felt that their employing district health board had provided sufficient support to engage in clinical leadership activities. Because remember also, the In Good Hands report had said that this was about identifying and supporting clinical leadership and actually creating opportunities across the spectrum of service delivery for healthcare professionals to get involved in such activities. So only 36% said yes here. It really needs to be much higher than this. And you can see that there is a bit more variation across the board from the southern region where I reside, down closer to sort of 28% or so, up to the better performing DHBs, closer to 40%. We asked about teamwork, whether respondents felt that professionals in their district health board worked together as a well-coordinated team. Now again, if we go back to the Skelly and Donaldson definition, which I put up to begin with, there is teamwork built into that definition, because this is about peers overseeing one another's work and having joint responsibility and working as a well-oiled team, essentially, in the care of a patient. And you can see here that 57% agreed that they work together as a well-coordinated team, with a bit of variation again across the districts. We asked about speaking up. This is a very, very important question, and that's because if you or I were admitted to hospital, we would probably not want to be treated by one of the 31% of our respondents who said that they didn't feel comfortable speaking up if they saw a problem, potential problem with patient care that could lead potentially to harm, either permanent disability or at least short-term disability. This really should be higher. Some would say 69% is good, but it really should be 100% of respondents saying they feel comfortable speaking up if they see a problem with patient care. Now, in order to look at progress between 2010 and 2012, the only way we could do this was to take the hospital specialists, because it was specialists only that we surveyed in 2010, and then of course we included specialists as well in 2012. So we took data from both surveys, the specialists only in 2012, and generated the Clinical Governance Development Index, which was an index of 6 questions from the survey, which were weighted according to responses, and then given an index score across those 6 questions. And so you can see that down at the very bottom, the mean had improved by 8 points, from 46 to 54% in the 2 years between 2010 and 2012. So we felt that this was quite a positive improvement over quite a short period of time. But when you look across the board at the different districts, some have made really quite marvellous improvements. 20 points in the case of South Canterbury, 17 points in the case of the Hawke's Bay and Taranaki DHBs. But then when you go up to the top, you can see that the West Coast have gone backwards by 5 points. We have responded to the media actually at the time, who went straight into beat-up mode, and we found that actually the numbers of respondents in the West Coast were not enough to give us confidence that this was a reasonable portrayal. This is one of the smallest districts in New Zealand, and the hospital specialist numbers are really quite small. But a number of DHBs have made really quite good progress. What was most interesting about this exercise was that by 2012, our districts were really quite comfortable about being ranked and rated in this way. There was not controversy that we had had in 2010. And that was partly because this was a partnership project, and they had come to terms with the fact that clinical governance measurement was an important component of their activities in terms of clinical governance development. Now, our reports are full of tables that look like this. So if you're really interested in regression analyses, you can go to our reports. This is just one example that I'm going to show. So this is the results of a proportional odds mixed model regression of the relationship between various background factors and familiarity with that concept of clinical leadership, which I put up earlier. And what's important about these regression results is that it gives managers, policymakers and so forth some indications of where they should be investing their efforts in order to improve clinical leadership, clinical governance across the board. So what this shows is that females, and these are statistically significant results, had less likelihood than males of being familiar with clinical governance concepts, that those older than 30 had more likelihood of being familiar than those in the reference group, 20 to 29-year-olds, that those with more than 15 years of work experience had a higher likelihood of being familiar with clinical leadership than those under 5 years. The 5 to 15 years is not a statistically significant finding. And then all professional groups had less likelihood of being familiar than doctors. So on to some of the key findings from the case studies. As I said earlier, I visited 19 of these district health boards and interviewed 165 people. And we have a large section in our report that discusses some of these key themes in much more detail. So I'm just going to touch on them. One of the most important ones really was the definition of clinical governance. There is no national definition in New Zealand other than the In Good Hands report. The Minister said that this was a document that he expected each of the districts to act upon, but it was never turned into a sort of full-blown policy document with clear instructions for how the district health boards should go about developing a clinical governance structure. Now, many of the doctors especially said, I'm quite happy to be involved in this. I want to be involved in system improvement activities and quality improvement. I take this seriously. but I have no idea what this clinical governance means. I don't know whether when I see clinical governance, I'm not too sure what it is. So we need a definition. We need some quite clear recommendations of what this should be. Now, because of that lack of definition, we believe that this is one of the reasons why there were 19 different approaches to developing a clinical governance structure and system of clinical leadership. So no two district health boards were doing this in the same way. Remarkably, they were working in a vacuum from one another. It emerged that the chief executives and the chairs and so forth, certainly at the time, were not speaking with one another about this very, very important topic. They had a series of regular national meetings, but they weren't discussing this particular issue. They were going about it in their own way. So there was no cross-sector learning taking place, which we were really quite surprised at, and I think they themselves were also quite surprised at. We found that there were partnership models in place in every single case of the 19 district health boards, and some quite fascinating examples of partnership models, building this management clinical partnership. Now, this was happening at least at the top level of each district health board, and in some they had managed to get the partnerships happening right down at the front lines of care. Some of the examples that existed were a Senate-style clinical leadership council, essentially executive leadership team that featured 24 people. So every time the executive management team essentially met, there were 24 people around the table. And it really was a bit like a university senate. And they said they had created the structure so that everyone who might be implicated by a decision that the district health board was taking on behalf of that geographic population, so it included the public health service or the public health medical officer of health, which is often quite separate in New Zealand. It included some GPs who work for the separate primary health organisations, the IT chief. They were all there sitting around the table, and they said that they wanted it that way so that everyone was involved in the conversations around how they might improve the system. Others had much slimmer partnership structures in place that probably would be, you might say, quite traditional, including the chief medical nurse and allied professional, as well as the chief executive and the finance and the planning chief. We found that in several of the districts they had a clinical board, or some called it a clinical council, in place. And this was quite important in terms of breathing life into the system of clinical governance. And so the clinical board, in some cases, pre-existed the governance policy announcement of 2009, but in many cases it had been created as, in part, a response. And so this was a board that featured a range of professionals from across the spectrum of care, so the allied professionals, the laboratory, the pharmacy and so forth, as well as medical specialists in nursing and others who had professional roles. And so this was a board that could host discussions around clinical concerns, as well as receive reports from various parts of, especially the hospital, but also the community, that clinicians could both monitor performance in a certain area, such as, say, laboratories or medical errors, and then have the capacity to do something about. Now, in one of the most powerful and important cases, this clinical board had the power of veto over every single other decision that might be taken in its region. So it had the power to veto decisions taken by the elected and appointed district health board. It had the power to veto the chief executive's decisions. And that was because the chief executive had argued very strongly that if we're serious about breathing life into clinical governance, we need to really put the system in good hands of these healthcare professionals who sit around this clinical council table. Now, the chief executive also had a role in the clinical council, so was a party to most decisions in any case. But they had, what I felt at the time, and continue to believe, the best, most robust structure of clinical governance in place. And that was partly to do with the leadership from the top of the chief executive and of the chief medical officer. And then just the last couple of points. We found, almost without exception, that getting medical specialists engaged, seeing that they have two jobs, a major challenge in many of the districts. In some of the smaller districts in New Zealand, and I don't want to digress and talk about the problems that they have in some of these districts with retaining staff, there was a very, very small core of doctors who were very committed to system improvement. But they said that they had great difficulty getting their colleagues interested in anything more than just coming and doing their clinics and going home again. Now, in the bigger district health boards, there was more of a critical mass, but we also routinely heard complaints about the difficulties, the challenges of getting the doctors especially, as well as other healthcare professionals. We also heard nurses saying the same thing, seeing that they have the two jobs, performing professionally well, as well as improving the system. We found that allied health was often a sort of a poor cousin to nursing and medicine when it came to the clinical governance structure. Now, in some cases it was a belated addition, in others allied health reported through the nursing directorate, and this was the source of some concern in those particular districts. And then finally we found that there was really a dire need, and remains in New Zealand, a serious need for more training in leadership for healthcare professionals. We're not fortunate enough to have a leadership academy as the NHS has. We should have had one about 3 years ago, but through various challenges in the policy development process it never happened, and still has not. And so what we have in New Zealand is training taking place again on a fairly ad hoc basis in each of our 19 districts. Some of them do it really quite well, others do it at best, you might say, poorly. And then the very last point, and we argued this more than this being a finding from the research, but 1 or 2 DHBs have done this quite well. They've connected the rationale for clinical governance very, very closely to quality improvement. They said that this is why having a different structure in place, operating differently, is important, so that we get quality improvement clearly within the sightlines, within the radar of the District Health Board. So just to draw some very brief conclusions. I started out by saying that this is an idea that was invented in the UK. We've imported it into New Zealand, drawn on much of the conceptual foundations of clinical governance from here. And then we've made quite good progress in a fairly short time in New Zealand on clinical governance development. There's a lot of commitment in New Zealand to this, although of late I'm not too sure that I could say that with such confidence. There have been a number of bold steps, and I could talk at much greater length about some of the initiatives in different district health boards in terms of working to advance clinical governance, but also a huge amount of variation within our healthcare system and the approaches taken. Unfortunately, not necessarily a learning culture in terms of being able to draw on the experiences of the different districts. And I think this is one of the greatest opportunities, both within our country as well as between our two countries, is how we seek to draw upon the experiences of one another, because so much can be gained through taking such an approach. Well, thank you very, very much, and we greatly look forward to your questions. Very much looking forward to the after party, being the 4th and final lecture. Thank you very, very much for coming along this evening. Lectures don't happen without willing participants, so thanks to each and every one of you for coming along this evening. Thank you.
Well, are you going to stay here?
No,
this is very technical. I mean, the choreography of this is absolutely essential to get right. Well, first of all, can I just say what a wonderfully elegant presentation we've just been privileged to hear. And as I sat there listening, I could think of so many read-across points with what we've been doing in the UK. And I'm not sure that our performance has been as strong as that which you've outlined in New Zealand with your own reservations. But it's not for me to comment, because we're very fortunate enough tonight to have from the Department of Health Dr. Anna Dixon, who is the Director of Strategy and Chief Analyst in the Department of Health, but may well be known to many others for her previous role, which is as Director of Policy for the King's Fund, the major health think tank, one of whose reports was referenced by Robin in the course of his lecture. So the choreography from now on, I'll invite Anna to make some comments, and then I'll invite Anna and Robin to join me at the table. We'll take some questions and have what I hope will be a further discussion between ourselves. So Anna, you're very welcome, and thank you for joining us tonight.
So thank you very much, Malcolm, and for the Foundation for inviting me to respond to Robin this evening. I thought that I would use some illustrative quotes. As a civil servant, one resists writing one's own words down on slides. But I think they will help to give a flavour of the journey that we've been on here in the NHS in England around this theme of clinical governance and leadership, which we've heard very eloquently from Robin about how that idea in effect got exported and developed up to the present. And obviously, as Robin hinted at, obviously the idea gained particular credence in the sort of 1990s. Although, of course, the underlying principles of clinical governance had been around in different guises for a long time, perhaps in many historically really more focused on sort of clinical governance almost being an individual responsibility. And I think it was through a number of different reasons, a recognition that you couldn't secure quality just through professional regulation and securing the skills and competences of a particular individual, but with teamwork and with the complexity of healthcare, much more important that the emphasis of clinical governance being something that was a requirement of boards and the leadership of organisations delivering healthcare. And in policy terms, it was really a first-class service back in 1998 where this idea was set out, and indeed it was supported by, at the time, a change really in the statutory duties of boards, that quality should be there alongside finance, giving it equal emphasis. But also, as I thought Robin really drew attention to, this idea that underpinning that is a culture of continuous improvement and systems to support that. And so really, if that is a founding aims, I suppose, of clinical governance, to make quality as important alongside finance and to develop continuous improvement, I just want to reflect really on how far have we come in achieving those things. So around this time, of course, there was also a number of external policies put in place to support this, including creation of NICE, producing clinical guidelines, national service frameworks from those, setting out what good looks like in different clinical areas, the Commission for Health Improvement, interestingly, at that time not really a regulator, but it had the term improvement in its title, but very much a sort of external body coming and looking inside to check whether those systems of clinical governance going on within hospitals particularly were effective. Interestingly, alongside this, and I think a theme for me that perhaps didn't come out in the New Zealand case, and I'd be interested in the debate, is the role of data around data to actually measure both the clinical quality of care, but also patients' experiences of care. And it was around this time that we launched our National Patient Survey Programme, which I think has been held up for quite a long time and copied up to some extent around the world. But how was this actually implemented? And I think there was a struggle because there was a lack of data. I think boards often looked to the individuals, the medical director or the nursing director, to effectively sort of delegate this responsibility to them, and often to delegate it to a subcommittee of the board. And I suppose the processes that were adopted were actually borrowed from financial governance often, so assurance, audit, internal audit. I suppose reflecting, I would say, something that was a bit more retrospective and compliance orientated, and certainly not the sort of spirit of the flavour you gave of the contemporary definition of clinical governance around clinical leadership and improvement. So where did we go next? Well, we had a clinician, Lord Darcy, as the Minister of Health, and published what was known as the Darcy Review, but High Quality Care for All in 2008. And that, I think, really set out a very clear quality framework, putting safety, clinical effectiveness, and actually patient experience there at the heart of the concept of quality, and therefore, clinical governance not just being about clinical effectiveness and safety, but also about sort of making sure that people had a good experience of care, hear words of compassion, dignity and respect being used. And again, at that time, we'd sort of moved on with, to, I think, the next iteration of our quality regulator. in terms of the Healthcare Commission, and I think was transitioning into the Care Quality Commission following that, with new enforcement powers. So again, this sort of internal focus on clinical governance in our systems always seems to have been accompanied by policies that have been around strengthening external scrutiny and regulation. Again, we had NICE being asked to produce sort of quality standards, and the idea that organisations should not only produce financial accounts but quality accounts. So different initiatives there, and in terms of moving ahead with the data that was available, initiating the national collection of patient-reported outcome measures, which again, Andrew's here and was a great Valent's great champion of those, having pioneered their use in Bupa under his leadership. So you know, we're moving on. We're still focused very much on quality. We've added in a sort of this perhaps a bit more focus on patients, and there was beginning to be a view that we needed to develop clinical leadership within the NHS, and people will know that some young doctors were supported as Darcy Fellows, named after Lord Darcy, his clinical leadership and fellowship schemes. So we had that, but of course we have then had to have a period of quite deep reflection because of the events that had occurred at Mid Staffordshire Hospital that Sir Robert Francis investigated and reported on, and really highlighting, I suppose, a failure of clinical governance there. And again, sort of really here, I think, adding to our concept of clinical governance, that it's not about processes and systems, it is about the culture, and part of that culture is about leadership, not only by the board, but also clinicians at every level in the organisation. And you know, the main criticism really that was of the board was that they had focused on finance over and had lost sight of quality, and certainly lost sight of patient care. So in terms of that test of clinical governance, it had clearly failed. So that just outlines it really. So a real sort of clarified that boards and indeed clinicians working inside organisations should be putting patients first, day in and day out. So there was an immediate response from the government in March, interestingly picking up that phrase at the end there, putting patients first and foremost. And obviously these reports contain many words and many recommendations and many actions and commitments. So I only highlight here a few of them that I think perhaps most pertinent to the theme of today's lecture from Robin around clinical governance and leadership. And here really illustrating and describing the critical role that boards do have around shaping the culture that promotes safety, effectiveness, and so on. The sorts of actions that are being now pursued following some sort of further reports. Obviously, again, there was an emphasis on strengthening the Care Quality Commission as an external regulator, but trying to make that, moving away from generalist inspection towards having expert inspectors. So people who themselves are the bit-backed peers who understand and know that clinical area, actually going on the inspections and reviewing those services. And that is the changes that CQC are still in the process of implementing. They've done their acute hospital under the new inspection regime, and are now just launching their approach to the inspection of general practice under the new, more expert approach. Interestingly, Care Quality Commission is also, as one of their sort of questions that they assess organisations on, is whether they are well led. I think a real recognition again that in order to deliver quality, it's necessary for organisations to be well led. There are a number of other reviews that the government commissioned in the aftermath of the Francis report. One of them I highlight here from Don Berwick, I'm sure known to many of you as an international leader in terms of health improvement and safety. And he was asked to look at the culture for safety in particular within the NHS and what was needed. And again here an emphasis really that at all levels the emphasis needing to be placed upon quality and safety as a top priority, and that really was emphasising a learning and improvement culture. And he made some specific recommendations about how we need to provide clinicians with improvement skills, and the Health Education England is working with other partners to see how that can be built into training and education. The other review that I wanted to highlight was Sir Bruce Keogh, who was asked to go and investigate a number of trusts who were outliers in terms of their standardised mortality indicators, and so he did in-depth reviews into those hospitals, but also provided a sort of overview of what some of the generalisable lessons were from those. And he really highlighted the challenge that he observed, that the lack of capability of boards and clinical leaders to use data to drive quality improvement. So part of that was accessing the data, but a lot of it was about how that data was presented, how it was interpreted, and whether it was acted upon. And again, there's been guidance issued to boards about what a sort of healthy board, how they can use that. There have been proposals made for potentially for boards to think about appointing a chief quality officer as an idea about, and rather than it just being sort of left to the medical director, recognising that there are a set of skills that a board could benefit from having in terms of assuring quality. So the last bit there really emphasising that point is making, that it's not about just having access to the data, but also knowing what to look at, being able to scrutinise that, and then use that information to drive improvement. So, as I say, it's this combination of both the boards and clinical leaders having data and having improvement skills. And I think there's a number of things that are going on to address that. But I think one of the things that sort of we're seeing going on inside hospitals in particular, and how they're organising, comes back to this point that I found very interesting, what Robin was saying about the accountability, about bringing financial and clinical accountability together, and creating clinical business units, they're sometimes called. We had a go at this called service line management a little bit ago, but really trying to align accountability for finance and quality at lower levels within organisations, recognising that the board can't hope to sort of reconcile this unless there's accountability within the organisation. So I think the recognition that clinical governance does need boards to create the right environment, but actually there also needs to be the leadership for and accountability at other levels within the organisation. So the government, together with other national partners, responded in more fully to the Francis inquiry in a document called Heart of Truth, which was published in January of this year. And I suppose I just think it sort of added an emphasis to another dimension, that we can have all the data, we can have all the business processes, but really part of the true sort of clinical governance is also to create an environment that's open for staff to speak up. And you again talked there about speaking up. We've currently got Robert Francis leading a review to specifically look at whistleblowing and whether staff do feel that they can speak up when they see things that are not in the interest of patients in terms of safety and quality. And so I think that is a useful addition and broadening, I think, of the definitions of real, to secure an environment in which there can be safe and high quality care. So I hope I've been able to sort of draw out some things from having a little bit of a look back at my take, at least, on policies and actions that have been taken around this clinical governance theme since the sort of idea really took hold in the late 1990s, and been able to draw from that some of the sort of ways in which clinical governance is being interpreted and implemented within the NHS. Have been by no means comprehensive, because there is an enormous amount going on. I mentioned the Leadership Academy. We've got senior clinicians going through executive programmes to hopefully have a new set of future clinical chief executives. So I've selected a few examples, but I thought I'd leave you. These are the things that struck me most, really, that we're still working on. Have we got the right board level capabilities? Have we really moved from a sort of retrospective approach of audit to a genuinely being focused on continuous quality improvement? Do we, at the right levels in the organisation, both have the right data and the skills to interpret it? Have we created that clinical leadership and accountability at every level? Is there a culture of openness and transparency? And where does the balance lie between internal governance and external regulation? As I've, I hope, also illustrated, that the two have often gone together, but I suppose the question is, where is the balance, and ensuring that the two are complementary and one doesn't crowd out the other. So I'll leave you those thoughts and hope that we can discuss them further together. Thank you.